And then we had started doing trans-caval puncture. So basically puncturing through a small area of overlap between the IVC and the pulmonary venous atrial wall in a few cases back then, which I'll talk about a little bit. But this is how people are getting back there. We didn't have any complications related to access to the pulmonary venous chamber for these patients. So the trans-caval cardiac puncture, I want to talk about a little bit. This has been our preferred approach at UCLA for the past 5 to 10 years or so. It turns out that when these patients are operated on as children, which is almost always the case, the conduit length is not the size of a full-grown adult heart. And so as the heart grows, the IVC is typically pulled up around the pulmonary venous chamber, and there's almost always at least some overlap between the IVC and the pulmonary venous chamber. And so you can take advantage of that. If you recognize it, you can take advantage of it, because a puncture in this area is much easier than through conduit material, which can be extremely difficult, often calcified, nearly impossible sometimes to get across. And so with careful evaluation, usually we do a preoperative CT scan, which shows the conduit very nicely. You can determine this is there and go after it at the time of the procedure using either TE or ICE. And this is just we just published this, I think, like a month ago, showing that, this is definitely a feasible approach for extracardiac Fontan patients to get to the pulmonary venous chamber, which is where these arrhythmias are coming from in these patients. So again, you do a venogram, look at the edges of the conduit on fluoroscopy. You can figure out where you're going to kind of probably target the puncture, and then use ICE to make sure that you're in the right spot, or TE in some cases, especially in the older cases we had done. So here's an example of ICE, just showing the conduit border right about here, and the transseptal puncture performed right below the level of the conduit into the morphologic right atrium. The other advantage of you have a direct approach. So some people will go retrograde and use stereotaxis for this. I think the advantage of the prograde approach is you can get multipolar catheters into the pulmonary venous chamber for high definition mapping of complex arrhythmia circuits. And in some cases, even we found this useful for cryoballoon PVI in extracardiac Fontan patients with atrial fibrillation. So again, the direct approach does have some benefit in terms of mapping and also ablation for these patients. And so it's been our preferred approach. And we basically found that if you have preoperative CT scan that demonstrates definite overlap between these structures, we're able to do this trans-caval cardiac puncture in the majority of patients without any real complications or issues. This is just a case showing this, where we've done a conduit or a trans-caval puncture here right below the conduit, and we have this atrial reentry, likely related to where this IVC had previously been oversewn here. It's actually it's also something we see. And on the left side of the screen here, this patient also had what's called twin AV node tachycardia, which I'll talk about briefly. But it's a fascinating form of tachycardia mechanism, where you have duplicated conduction systems, duplicated AV nodes, and in tachycardia you have antegrade conduction over one AV node and his Purkinje system, and then retrograde conduction over the other. So you form a complete circuit using the two conduction systems. That mechanism is seen in almost exclusively in the heterotaxy patients. Heterotaxy syndrome patients have duplication of either right or left-sided heart and thoracoabdominal structures. For twin AV node tachycardia, we see this really in the right atrial isomerism patients, where you have duplication of right atrial structures. This is seen outside the heart by aortic-caval juxtaposition down in the abdomen, typically a midline liver. And then in the chest, you see eparterial bronchi on both sides, basically bilateral right-sidedness in terms of the arteries and bronchi. In terms of the heart, complete AV canal is common. Total anomalous pulmonary venous drainage, double outlet right ventricle, and pulmonary atresia are very common. what you see, and this is just a recent map. This is only from a few weeks ago, but with these right atrial isomerism patients, you have duplication of the electrical structures in the heart, meaning the sinus node and the AV node. So the sinus node is a right-sided structure. You typically have bilateral sinus nodes and twin AV nodes in these patients. So if you look at this, this is a high-definition map of mapping His-Purkinje conduction. So all of these represent His and His-Purkinje electrograms, and you can see that there's activation. This is the right-sided ventricle and the left-sided ventricle. This is the ventricular septal defect here, and there's conduction along a His-Purkinje system coming from the superior AV node, and then simultaneously this inferior AV node has His-Purkinje conduction. That it kind of just meet in the middle. So this is the substrate for this twin. So if you basically have refractory tissue here and a timed extra stimulus, you can get reentry. You can get one of these to conduct antegrade and then recovery. So you can conduct retrograde and get sort of reentry through these twin AV nodes. The treatment for this is to ablate one of the AV nodes essentially. And typically what you want to do is identify the weaker of the two and ablate the weaker AV node. Also, preferably ablate the one that has the wider QRS complex associated with it. So this is an example of ablation for a patient with twin AV node tachycardia, and we're atrial overdrive pacing, so you don't see the accelerated. Typically you see accelerated junctional rhythm with this. But with atrial overdrive pacing, basically you go from a inferior QRS complex to a superior QRS complex when you're ablating the anterior AV node. This is just a quick plug. We actually are doing a study on twin AV node tachycardias because there's not a lot of data on these patients, and so if anybody is at a center that has experience with twin AV node tachycardia ablation, feel free to reach out to me at some point, because we're actually enrolling centers right now. We've got, I think, 12 centers so far that have enrolled and are submitting patients. That's just a quick plug. All right, so as these patients get older, we do see a predominance of reentrant atrial tachycardias, atrial flutter, but as these patients get older, we do see an increase in atrial fibrillation, essentially, and then once these patients are around 50 or so, atrial fibrillation seems to become the predominant atrial supraventricular arrhythmia, and it's becoming a bigger and bigger problem actually in congenital heart disease patients. This is, I showed you this earlier where we had done a trans-caval cardiac puncture to get a cryoballoon into to do a PVI in a patient, which maybe 10 years ago we'd not really have thought about doing, but it's becoming a bigger issue now, and there's a lot of ongoing efforts to look at how best to how to approach these patients in terms of ablation technology and what kind of substrate to ablate. All right, so the last category I talk about today is Ebstein's anomaly. This is a fascinating it's very rare. It makes up only about 1% of all congenital heart disease, but it's fascinating in terms of the different forms of arrhythmia that these patients manifest. It's been termed by Ed Walsh, who's known to be sort of the father of congenital electrophysiology, to be a natural laboratory for reentrant arrhythmia. And if you look at this list, this is just out of a review article that he wrote. These patients have accessory AV pathways. 20 to 30% of patients have accessory pathways. They do also have a fair number of atrial fascicular fibers. AV node reentry is not uncommon. They do have monomorphic VT, although it's very uncommon. And then when these patients get older, atrial MAC reentry, so atrial flutters, focal atrial tachycardias, and even atrial fibrillation are all common. So you can see any number of different mechanisms of these patients, and they're probably the most affected by arrhythmia as they get older. This is just showing an anomaly, an Ebstein's anomaly. So you have displacement of the septal leaflet of the tricuspid valve, and then on the right side here, you can see this is the inferior leaflet of the tricuspid valve, which is massively displaced. This leads to a third chamber here, which we call the atrialized right ventricle. So it's under atrial pressure, but it's right ventricular myocardium, and it tends to become very thin-walled and fibrotic over time. And this is source for arrhythmogenesis in terms of VT for these patients and sudden death for these patients. Really, interesting to look at how these patients were diagnosed early on. Some of the early investigators used transducers with an electrode on them so they can measure simultaneous pressure and electrograms. And you can see as they're towards the RV apex, you have this RV pressure and a kind of a late electrogram in the QRS. And as they pull back into the atrialized RV, the electrogram gets earlier. This is actually what you see with these patients sometimes with their accessory pathways too, as they get earlier in the atrialized RV. The HV intervals were noted to be on the long side because most likely because the septum is very involved in the fibrotic process. And there is a difference in the conduction pattern in the atrialized right ventricle and right ventricle in these patients, depending on whether or not they have a WPW pathway. So the proximal atrialized right ventricle may have a very early electrogram or early activation rather in the presence of WPW, whereas typically it's very late if there's no accessory pathway conduction into that area because it's sort of the latest area to be activated. Let me skip ahead. So I think that's kind of leads us to the next topic, which is just the EKG. And I think everybody knows that an examination of the EKG is very important for determining whether these patients have WPW or not, because WPW in Ebstein's is classically a very atypical pattern. You expect to see a complete right bundle branch block in Ebstein's anomaly without an accessory pathway because conduction is activating this atrialized right ventricle typically very, very late, especially when it's a severe Ebstein's, and so they should have a very pronounced complete right bundle branch block pattern. If there's an accessory pathway, however, this area is pre-excited, but it does take a long time to get here through this atrial myocardium and through this diseased RV. So these forces generally cancel themselves out, and you end up with an atypical pattern that is not a complete right bundle branch block, but also does not oftentimes look like a typical WPW with a delta wave. So very important to look for that that right bundle branch block in patients with severe Ebstein's. If you eliminate the pathway, this is the same patient after catheter ablation, you develop a complete right bundle branch block. So this EKG here on the left you should be very suspicious for accessory pathway conduction. This is an example at our center with this essentially the same finding. This patient came in with recurrent SVT. This is the baseline EKG here. You can see that there is some slurring in some of the leads, but it's not pronounced in some of them and could be easily missed. And obviously doesn't have a right bundle branch block in the initial EKG. We found a septal accessory pathway that was ablated. And after that, the EKG changed, but it was still not a typical right bundle branch block. And we ended up finding another pathway in the lateral annulus that was ablated. And then at that point, you start to see what looks more like at this point, this patient had no VA conduction and AV block with adenosine, and we couldn't find any more pathways. I think it's important to remember that patients with Ebstein's anomaly who have WPW or accessory pathways in general, 50% of them will have a second accessory pathway. So, after you ablate the first one, be on the lookout for, I think examination of the EKG is important, but to be on the lookout for other pathways. These pathways can be quite challenging to ablate in Ebstein's anomaly because of various factors that include things like the fractionated electrograms in the diseased, in this atrialized right ventricle can really obscure the correct location of accessory pathways because some of these fractionated electrograms can extend. So for instance, in tachycardia, orthodromic tachycardia, you may see fractionated ventricular electrograms that are later than some of the earliest atrial electrograms, and it can be difficult to distinguish these without pacing maneuver sometimes. The AV valve, the true AV valve annulus is where these pathways exist. But the true AV valve annulus can be difficult to appreciate because it's oftentimes very diseased again, and the valve is displaced. Patients have distortion of the atrial anatomy and the ventricular anatomy, which can create some difficulty with catheter stability. And finally, they oftentimes have multiple pathways or broad pathways. The pathways themselves tend to align with where the valve is most displaced. So septally and inferiorly is the most common location for pathways in Ebstein's anomaly, and that's been reproduced in multiple studies. You can see here in this Boston group, septal and posterior, although you can get them anywhere around the tricuspid valve annulus, obviously on the mitral valve annulus, but the vast majority are in this areas where the tricuspid valve is most abnormal. This is I think kind of an interesting case. It's a patient who had Ebstein's anomalies in his 30s, came to us with this wide complex tachycardia, had a history of 3 ablations in childhood in India, and continued to have palpitations and sort of lived with it for many, many years, but finally came to see us. And this was documented, I think, just in a routine clinic EKG when he came to see us. This is his sinus rhythm EKG. You see this, what looks like a right bundle branch block pattern here, and massive P waves, which is consistent with Ebstein's anomaly. So we took him to the lab, and actually this is where I have the audience response questions if anybody wants to participate in this. Let me move this over. So basically we're atrial pacing here, and the question is, what happens with atrial pacing? What's the finding with atrial pacing? If anybody wants to take a stab at that.
Jeremy, while they're looking at that, maybe I can ask a question that came through here. It's related to patients you take for intraatrial reentry, what the endpoints for ablation should be. Should you try to eliminate every tachycardia that you induced, or just focus on the clinical?
Good question. Our approach is to eliminate all of them. We're pretty thorough. I mean, we found that, if you have an inducible sustained arrhythmia after you're done ablating, even if it's not the clinical one, most likely they're going to show up with that arrhythmia later on. That's been our experience, at least. We're actually looking at that in a form of a study right now. But what we do is we'll look at conduction block across all the isthmuses that we ablate, and we basically go to non-inducibility, if possible.
Okay, thanks. Well, it looks like an even split.
Okay. I don't know if this is really a fair question, to be honest with you, but basically you have this right bundle branch block here at baseline. And then when you pace, this right bundle pattern becomes less prominent. Let's see how to move this out of the way. So essentially what this would suggest is you may be preferentially conducting over the AV node and less so over, over the pathway versus the AV node with atrial pacing. And this is sort of a clue that there's actually an antegrade conducting pathway here. So the answer I would have chosen would have been progressive pre-excitation, but it's not really probably the easiest question, not the fairest question in the world. All right, this is the next one. I think this is more useful though. So this is during tachycardia. You have this wide complex, this is this clinical tachycardia. And then we're delivering a timed atrial extra stimulus here. This is in the atrium here, so we would deliver a timed atrial extra stimulus. And the question is, what does this maneuver show, essentially?
All right, well, they're looking at that. Another question here. Any hemodynamic consequences to either transbaffle or extracardiac Fontan puncture, particularly with a cryosheath?
Yeah, I think the concern would be, if you're potentially leaving the vascular space and outside the heart, and could you have bleeding? We obviously worry about that. It just it hasn't turned out to be much of an issue like we initially would have thought. I think it has to do with these are all post-operative patients. So there's a lot of, after surgery, there's a lot of bleeding in that space, and then that becomes adhesions over time. And it kind of contains any kind of bleeding concern you might have with the puncture, as long as you're doing it, in that true space when there's overlap between the structures. So we have not seen any bleeding issues so far with that approach. And then the other issue obviously would be, is there going to be a residual shunt, especially with the large, like the flex cath sheath for the cryoballoon. And I think there's been some concern that, maybe we should be closing these off with a occlusion device at the end of the case. I think that's what we did on that one case. But typically with the smaller sheaths, we've not seen residual shunts after the puncture. So like with typically we use an Agilis, we have not seen any residual shunting on follow-up surface echoes or any right to left shunting with hypoxemia afterwards. So it doesn't seem like we've had any problems with either one of those things. Okay, so I think it looks like most people said resetting of an atrioventricular fiber. That's actually the right answer, which is great. I'm not sure this is even a fair question either, but basically there is a his deflection here. It's, you have to look at the previous strips to see this, but there's a long VH time here. So there's a long VH tachycardia. And then this is an atrial extrastimulus time to when the AV junction are refractory. And what happens is you advance the next beat of tachycardia. The next QRS is advanced with the same QRS morphology, which basically essentially proves the presence and participation of basically an anadromic pathway, whether it's Maheim or accessory pathway is hard to say, except that the VH time is very long. So you might be favoring an atrioventricular connection here. So very nice. That's the right answer, and that's actually what we found. So when we did the mapping, we actually mapped this retrograde. It was surprisingly, it was actually a short AV connection, but with decremental conduction properties and very weak conduction properties. We suspected this is probably a damaged pathway from prior ablation, but we were able to ablate this and eliminate this guy's tachycardia. The last thing I wanted to talk about with Ebstein's anomaly is this finding that just was published last month in Heart Rhythm. A lot of these patients have this very prominent muscular ridge along the true annulus. And the Boston group looked at a series of patients, autopsy actually, Ebstein's patients, and found this was very, very common. And it was actually associated clinically with SVT during life. So they went and histologically assessed and found that these patients, a lot of these ridges contained accessory connections, at least grossly, and some of them histologically. And they commented that, a lot of the times the coronary arteries actually ran inside these ridges. And so they pointed out this is an under-recognized structure for Ebstein's anomaly that may make a big difference when you're going after these and ablating them. Turns out this was not the first description of this. It was actually described in 1955. But there is a prominent ridge in these patients with a lot of times it harbors this muscular connections with accessory pathway fibers. And so I think it's important to realize these can be very broad. This is a case we had actually with one of these ridges here. This is looking from the right ventricle in towards the right atrium here. And you can see that the true annulus has this very thick ridge. The leaflets were attached much further down. And this patient also had a very broad connection here. We actually had to ablate several locations along this area to eliminate the tachycardia. So I think this probably is an underappreciated finding for Ebstein's anomaly, and it probably explains the high recurrence rates in these patients, among the other things we mentioned earlier. This is just an example of just a massively enlarged right atrium. As an Ebstein's patient who had CTI dependent flutter. He was going to have a valve placed, and so we wanted to make sure there's no pathways. We ablated the CTI flutter. The flutter slowed. I can't remember the exact cycle lengths, but I think it was to around cycle length of 400 and became 1-to-1. And we kept ablating thinking, okay, we just haven't interrupted the CTI. Turns out that he had converted to, or actually she had converted to an accessory pathway tachycardia with almost the same kind of atrial activation as far as we could tell from the catheters that were in place at the time. So we finally did a few diagnostic maneuvers, realized this was a pathway, and went after that. So just important to keep in mind multiple mechanisms in these patients, and you should always be thinking about what's common too, I suppose. Just dual loop I just want to emphasize dual loop reentry. This is an unoperated Ebstein's patient. This dual loop reentry was going around the tricuspid valve and the IVC, no prior surgery, but the IVC circuit actually seemed to be the driver here rather than the tricuspid valve circuit, I guess you could argue at that point. After surgery, especially tricuspid valve replacement, these patients can have very difficult to ablate annular substrates that include the CTI. We've been looking at this pretty extensively at UCLA. This is an example of a patient who had multiple outside flutter ablations, and I think even a prior ablation at our own center. We couldn't get to the CTI from either the atrial aspect or the ventricular aspect, and we finally, just from symptoms and we eventually decided to just get the catheter below the bioprosthetic valve. So we did a puncture to get there, and we're able to. This is just showing us puncturing below the valve. You can see we're staining the struts of the valve here. And eventually, though, we actually got the catheter through that into that little spot right there, and we're able to terminate the tachycardia, and fortunately no recurrence. So, but I think the point of this is just it highlights how difficult it can be to ablate below valves, and actually even annular rings in patients with Ebstein's anomaly. We just completed a multi-center study looking at this just earlier this year. These patients have with either a ring or replacement of the valve, have longer procedures, greater number of procedures, and longer fluoroscopy times in general. And if you look at the success rate, and this is all sites combined, ring and replacements had a lower success rate than either valve repairs or no prior tricuspid valve surgery as controls. And it was due almost exclusively to, these are all annular targets, by the way, so it was worse for annular targets, but the CTI was the culprit in a lot of cases, and focal atrial tachycardias along the annulus was the culprit in these cases. So we're sort of, promoting, I think a lot of people do this already, but we're promoting preoperative EP studies and kind of a low threshold to just ablate the CTI for these patients that are expected to undergo tricuspid valve rings or replacement, just because it can be extremely difficult to control those arrhythmias post-operatively. Mayo Clinic actually published something kind of similar a few years back, showing that even after a maze operation, CTI-dependent flutter is common in Ebstein's anomaly. So, it just goes to I guess, support the notion that you might want to go after these even preoperatively in some cases. I think there's not really any consensus on this yet, though. If we have time, it looks like we're actually out of time. I was going to talk about VT, but it's kind of a long topic. I don't know if we should just stop at this point.
Sure.
Okay, so basically that's it. Hope you guys enjoyed this. Sorry I didn't get through all the slides.
That was fantastic. Thank you. Interestingly, there's a device-related question. Maybe you want to just touch on it. That's probably a whole other topic. But
Sure.
The use of physiologic pacing in adult congenital heart disease, is that something you consider?
Absolutely. I think that's underutilized. We have been, there's some issues, I think, though. One of the problems, I think, is going to be that a lot of these patients have VSD closures, which are going to be very close to the conduction system in most cases. And then when you're going to if you're going to go after his pacing after VSD closure, I worry about a lot of scar in that area, and then long-term durability of the leads and the characteristics of the leads. But we've looked at it certainly with CCTGA, which we know those patients get worse with single site pacing. They develop heart failure pretty rapidly. So we've looked at his bundle pacing for those patients, and they actually seem to do the leads actually seem to be pretty durable, and those patients do pretty well after his bundle pacing. So, I don't know. I mean, maybe we could, the left bundle area pacing, branch area pacing, I don't know of any case reports. There may be some actually now in congenital heart disease, but there's probably going to be new ways that we can get to the conduction system and better preserve ventricular function, because, heart failure is also a very big problem for congenital heart disease patients, and a lot of it's pacing related. So I think there's definitely a role for that, but we're just at the sort of just learning about it right now.
All right, great. And I think you do talk about pacing in that review article that I mentioned. I'll try and put up online.